So here comes the big guy himself, and I think I really look up to him for a lot of good ideas and the way he analyzes situations, problems, and looks for solutions. The best part is he looks at a problem as an opportunity to solve it. Unlike most of us, we look at a problem as a problem and a hindrance. What he looks for in a problem is he looks for a solution hidden in the problem, and that's the way I think that's what a translational scientist and a clinician, a diehard clinician he is. And I don't need to introduce him. He's one of the chief mentors at the mentor program in Naran Netrale. And I guess, wherever Naran Netrale today is, I keep sharing with my fellow colleagues and all colleagues, wherever I see NN today is, I think a lot has to go to Rohit, what he's done with the organization. And he just kind of put rocket boosters in the organization. And I think every second publication coming out from India, probably in ophthalmology, has Rohit or Rohit associated with it somewhere or the other, or maybe one of the people who gave the idea. He's done path-breaking work in biomechanics and stromal molecular markers in refractive surgery. And he's won the prestigious Colonel Rangachari Award and overall best paper at conferences and Casbier Award at IRS. And over to Rohit. I think we will be in for a treat right now. So over to you, Rohit.
I will share my screen.
I hope we don't lose the internet while you're on.
Hopefully, this is so. Can you see my screen?
Yes.
Yes, perfect. Thank you, sir, for a very generous introduction. I'm not sure how much I really deserve it, but thank you for it, and thank you, the My Healthscape, Monish, and the team for giving me this opportunity. And thanks, Dr. Natasha and Dr. Gaurav, for allowing me to speak before you. These are my financial interests. I don't think it's going to have any impact on my presentation today. We've had some very nice talks on dry eye. How much do we know about dry eye of today, especially with the new normals? New normal or old normal, but there is a huge amount of conflicts about how much we know. These are two patients, which I'm just using new data, which was just a week back, 2 days, 8 to 9 days back. You can see that the T buds of them were, of normal quality, and Shermers were normal, mild MGD, they're not serious. And look at their OSDIs, both of them extremely bad OSDIs. And this is something which was very alarming, because they don't have any signs but they have tremendous amount of symptoms. And we treated them with the same medications, like the previous talk sir mentioned about we even treated with an EI for them, the IPL, which I'm going to come back to you. But like Dr. Kamal sir said, the question is about why one person improved. It's not about statistics, why this guy improved and why the same person did not improve. So this is where the whole crux of this situation is, that we need to figure out what was really different. And when you look at clinical ways of evaluating them, you hardly find an answer. So we went a little deeper. The person who did not improve had this extremely different nerve loop areas around. We call it as a microneuromas. Very classic of, it's like schwannomas or in any of your nerve endings. So these are all nervous, bulb-like features in your nerves, and extremely painful. And the patient just keeps coming off pain and irritation in many places. And unless you do a confocal, you'll never pick up. But these patients, there is no neuroma, but you can see those dendritic cells. And these are one of my favorite cells, because I worked on it for the last 15 years, because these are the ones which bring in a lot of, they're suggestive of inflammation. And people who know me and who work with me know that we work on the tears, just like how you do the blood. And this is very interesting, very, very interesting thing. And you will realize it at the end of my talk, why this slide is interesting. What is important here is the patient one, which had exactly the same OSDI pain and all that, all her inflammatory markers were all normal. And in this patient, all her inflammatory markers were high. So it means that the patient A had no inflammation, the patient B had a lot of inflammation. This patient got better because all your drug, whatever you're treating, is treating the inflammation, and you're treating, and here there is nothing to treat. So you are using cyclosporin on this, but the cyclosporin is acting on something which is normal. So if you're using IL-6 blocker, IL-2 blocker, there's nothing to block because patient does not have inflammation. But in the same thing, if you're looking at this patient has a very high IL-6, and look at the MMP9s, which your doxycycline and other things work. When you use a doxycycline and other things, they work on these factors. Look at the MMP9 is 30,000, and 10th on here, MMP9 is normal. So what is happening is when there's nothing to block, the drugs don't work. When there is something to block, the drugs work. So that is the most important understanding from these cases. And this is what I mentioned. Your nerves are unhealthy, and there is, so you have to treat him like a neuropathic pain. And here you treat him with your drugs. So as ophthalmologists, these two cases are very, very important because they highlight some very important aspects of when treatment works and when it does not work. So you can use in this patient, I'm sorry for spoiling the screen here, but you can, in this patient, you can treat whatever drug you want. And that is what is important. You treat 100 drugs and the 100 different drugs will not work. So that is what is very important. And there are multiple ways of evaluating this. What is most important is I'm not going to go into too deep of this because I think Natasha is going to cover this is the question which Dr. Kamal asked in the morning. How do you look at the optical quality of a tear film? How does it see? There's a system called OCAS which looks at the vision tear film breakup time. Basically, what it does, it is like your abrometer, but it looks at the aberrations from your tear film from the first blink, and from your first time it blinks at 0 to what happens till you blink the second, till you do the second blink. So from here to here. So in that period, you can see the seconds here, 2 seconds, 1, 4, until around 20 seconds. What really happens to your tear film? If your tear film is perfect, it should be in that green zone. And when you have this is, you have a problem. This is what happens when you imagine this patient is your multifocal IOL guy, and what happens is you are made him have so much of scatter, and you scatter, and every time you start looking at, have I put it in the angle alpha, or is the kappa longer, or should I put it in, is it on the visual axis, non-visual axis? So there's so much of discussions revolving around the optics of the lens and the optics of your bag, but everybody fails to understand that there is something happening on your tear film itself. And the tear film is probably one of the most unstable thing which creates all this problem. And so when you look at this, you can imagine how much the tear film has an impact in your quality of vision. Confocal microscopy I just mentioned, and these cells are the ones you're targeting it. And if you have this kind of a cells before your surgery, once you make your incision anywhere, this increases, and this can have a huge impact. And I've mentioned about this, that these are the most important thing which creates tremendous amount of impact on your quality of life and quality of vision, and you're non-responsive to treatment. These are all factors which are important. And this is last 17 18 years this has been part of my work. And when you look at refractive surgery, most important thing which sometimes it is, we talk about many things, but we miss the epithelium. And thanks to MS39, now a new tool which looks at the epithelium to stroma. And the most important thing what I like is it gives you a new feature, epithelial Zernike. It has never been done before. That means it gives you Zernike polynomials or aberrations from the epithelium. Why is it so important that epithelium is, to us now, to as a refractive cataract surgeon? That's what I'm going to talk in the next few slides. A healthy eye with a good ocular surface has a good epithelium. This is an unhealthy ocular surface. Unhealthy ocular surface has tremendous amount of change. You asked me a question, what happens with the biometry? If you are doing a biometry on this patient, let's assume he's got a cataract, there's a no cylindrical power here. That means it's a healthy eye. So cylinders also comes from an epithelium if it's irregular. And the whole of cornea is perfect. Imagine this patient here has an, you're doing a biometry. The patient has close to around zero point 0.5 to zero point 0.8 diopters of astigmatism from the epithelium itself. And imagine epithelium is a dynamic process. It can change the cylinder. You assume that if the patient has a 2 diopter cylinder from the ocular, from the whole optical system, around close to a diopter is coming from the epithelium. And this is because there's a huge amount of coma, and this is because there's a whole amount of epithelial irregularity. So what really happens is that these have a huge impact both in the cataract surgery, also in the refractive surgery, especially if you're doing a contura. One of them, you can see the amount of changes. These are all poor ocular surface. The machine is the laser has to treat on the stroma, but the machine assumes that it has to treat the whole thing, and your whole amount of cylinder, what you see, is coming from the epithelium, and these are all very poor ocular surface. And this is just a small diagram explaining about the importance of stromal surface and how the stromal surface can impact your quality of vision. And all this has what I'm trying to say is all this has a huge impact on your quality of life and quality of vision as a cataract and refractive surgeon, because poor epithelium means poor lipids, poor meibomian glands, and that can translate. I'm not just looking at what happens after you do surgery. I'm talking about what happens before, when you're evaluating, because this point was raised by Dr. Kamal in the beginning about what can happen to your biometry and multiple things. Same thing with your cataract. You can have a perfectly normal topography here. It's everything is normal, and your normal tear breakup time, the surgery is done, and then the patient starts having problem. And every time we look at the eye, the optical system, but here again the same dendritic cells, and look at this patient who has these kind of preoperatively kind of cornea, who have a very poor ocular surface, they have a very poor heavy dry eye, can end up with these kind of system post-operatively. And this is the kind of tear film optics you can get. It drops down, and the quality of vision is always poor, and you can't really treat them after surgery. And this is again a problem with your epithelial cylinder. And here also, post-operatively, you still end up with some amount of a residual cylinder after few months, because when you use all these technologies, we know how it's changing. This is what happens when you treat a patient without taking care of his dry eye initially. You have a normal looking OSDI, and you can see that when the OSDI increases, the nerves are not healthy. You operate and their epithelium is bad. These are all pre-op patients. You can see here, these are all pre-operatively patients. Once you do a LASIK surgery on them, especially with the nerves like this, a healthy one, decent, and this is poor, you end up with the nerves like this. This is what happens. This is post-op. This is around 6 months. Your regeneration is good. This is decent. And look at this. The nerves are just not regenerated. And look at this. This is what guys who are going to come. So basically, you have to catch them at this stage where you should probably try to treat them and not just jump into a surgery and end up into a problem. And because if you do the post-operatively, they are completely, look at the epithelium here and look at the epithelium here. Look at this, the whole irregularity out there. So that means your nerves, ocular surface, and all this is a beautiful dynamics which can mess around with this. And this is a word I use in my room. This most dangerous phrase in English is that we have always done it this way. And the different ways of treatment. One of the ways I want to bring in the EI, which is it's like in laser pulse-based therapies. And I'm sure Natasha is going to speak about it. You use 5 flashes on the lower lid, and the way it acts is it's a small video we had done. As it uses to the zygomatic nerve, and then your trigeminal complex, and your efferent pathways, which goes to your lacrimal and your it goes to your the lid, the meibomian glands, and just helps in trying to bring in simulation of this nerve. So it's actually working on the nerves which supplies this glands, which brings in tears in your nerve fibers, in your lipid layer. We did down work on your operative dry eye, and these are the number of patients. Inclusion, exclusion is something similar. And we found that, of course, we don't really expect it to change, but there was a change in the OSDI. And what is important is pre and post, there was a huge drop in the OSDI, and that is what is very important for us. We wanted to see if it really works. We brought in some molecular signature work, and this is work done by Sharon. You can see that all those cells which are responsible for bringing in a lot of pain, irritation on all of them have actually reduced, which means that there's a lot of change happening out there. And this is one of those which I showed why we need, because these things has to be blocked by procedures like EI and all these factors. The last part of a few more slides. This is one of my oldest case. This just came 4 or 5 days back. It's a pilot by profession. This was in 2009. This case is very important because a lot of people who know my work, at 2009, we didn't even have a lab. We didn't have anything. But I was still very passionate about collecting the tears without knowing what I'm going to do with it. And we had done a confocal microscopy and all that. And this is 2010. He had come, and 2009 was the first. This is the case file of that. So interesting factor here is that this is a keratoconic guy. And because he was a pilot, I didn't want to operate him because he would lose a job. And I kept him serially following up for a long time. He was stable. And from 2019 to 2020, he started showing this change. I was a little surprised because it was something very drastic. And this is a time he was no job because he was off job for some time. And you can see that the nerves had all these cells, which I mentioned, which the inflammation has set in. Now, interestingly, what had happened was it was actually a penta. If I had just used a pentacam, it would look like there is a progression. But actually, it was not a progression. It was actually an epithelial change. You can see the change from here. That is where the MS39 is a huge new revolution in topography, because it gives you everything at one go. If I had a pentacam, then this is what it would look. If it had, and now I know it is whole of this change is induced by an epithelial hyperplasia. And this is a beautiful case, which means that it was just the factor of dryness there, an ocular surface change, which made him change. And I did his tear cytokines was higher, and this was a keratoconus guy, and he was staying. And these procedures like EI or one of these things, what happens is reduce the inflammation, and you can see that these inflammation, this is not the same patient, but you can see that when these inflammation get reduced, and you don't see them on this, all of them gets blocked. What happens is your inflammation actually gets blocked. And this is where I'm saying is, this is a great procedure before you do. Now I use it even before I do a cross-linking or eye rubbing, if I'm waiting for something. So it's just more dry eye. The various other areas where you can, basically it is reducing your itch factors, which is one of the most important thing in your practice. So it is very important to look beyond just dry eye. And it's just an ocular surface discomfort is what we need to see. And to sum up, dry eye has an ocular surface impact, has got ocular surface disease, has an impact in every known procedures. Treating them before you do any surgery is probably the gold standard. And even when you are having patients with glaucoma medication intolerance, or you have patients with keratoconus with eye rubbing, or pre-PRKs, or any of these procedures, I think I would use these procedures because it's a fast acting and nobody has time to keep putting drops for many, many days. So these are all this I have anyway summed it up. It's got a huge role in pre-refractive surgery. Thank you.
Thank you, Rohit. I think that was a beautiful summary. You just breezed past everything. You make everything what you do sound so simple. And yet I know there's a lot of hard work, sweat, and thoughts and ideas which go into it. And I tend to agree with you. I picked up this idea again from you. Earlier, when I had that EI machine, I was only taking up the extreme and the chronic patients, because maybe at that point I didn't have much the way it would work. And over time, I started taking my even early dry eye patients because I realized I heard one of your sessions that it's apart from the dry eye, it's the rubbing, the mechanical irritation, which tends to aggravate it. And to my surprise, I'll be sharing a little bit of my data that even the mild dry eye cases with the therapy, they became absolutely fine because I took away that little irritation, which was probably prompting them to rub the eye, itch, scratch, and cause more counter inflammation. So I think that that's another great leap from your book. I think by the time we've finished, I won't have much to speak in my session because everything will be covered. So I'll be breezing past fast. Dr. Gaurav, is Gaurav there? Dr. Gaurav? No, I don't think he's there. Dr. Rao, I just like your take on what Dr. Rohit has just said regarding the health of the epithelium and the way it, it concentrates everything in it and around it. Dr. Rao also is not here. No?
Basically, health of your epithelium is driven by health of your corneal nerves.
Mhm.
So if your inflammation, if your nerves are healthy, it's a beautiful hemostasis. They are all connected. They need the epithelium need hemostasis control from the corneal nerves. So one of the factors is when the nerves are poor. That's why when you post-operative healing, when the nerves are poor, your epithelium heals irregularly. And now with this new technologies we are seeing, we can even measure the epithelial cylinders. How much does the epithelium contribute to your cylinder compared to your total?
Absolutely.
And which probably we would never really think about it in the past because for us, topography is everything.
So a lot of times when you have a bad epithelium, so by this discussion, would it be a better idea to go in for a surface ablation, take away that epithelium and let it grow back again, than go for a flap bait procedure?
If you have a bad epithelium and if you have a high OSDI, it
Mm-hmm.
means that is a highly inflamed eye. If you do a PR case, even if you use mitomycin for 3 minutes, which we nobody uses, you'll have a scar.
Uh-huh.
So if you have a bad epithelium with the poor, very high OSDI, with the poor ocular surface, you wait for 4 5 months, treat him well,
Before you take it up.
then do a LASIK, then you do a PRK because you burn yourself very badly on treating on a very inflamed eye.
Mm-hmm. Dr. Fogler, your take
I
on
think
what Dr. Rohit just
yeah,
said.
absolutely, I agree 100%. I agree with usually with most of his points.
No bone of contention.
See, the thing is, especially what happens is when you do a cataract surgery, especially with a premium IOL, and your patient is unhappy and post-operatively when you see, and you find that there is some astigmatism which was not there pre-operatively, you should not be in a rush or a hurry to go ahead and do a PRK or a topo-guided treatment to try and remove that.
Mm-hmm.
Because often it is because of the surface irregularity. So as Rohit mentioned, that first treat the surface, your problem is most likely it's going to go away. So
I
I'm very cautious, especially after any of these situations. Even if the patient comes to me for a second opinion and looking for a solution to get rid of that, I always say that I explain the situation to him, do all the necessary tests, and start therapy, and then we reassess at 1 month, 3 months to see that whether these findings are remaining consistent or is there any variability. And then you take a call on whether you need to do an additional procedure. And in a majority of them, I find that you actually don't need to do a second procedure. You can treat the ocular surface, and as this ocular surface improves, definitely the patient's symptom goes away.
you see, I think I couldn't agree more with you. The reason why probably ocular surface is actually shot out into our purview also is because surgically probably we're reaching the level of perfection, and the patients being more demanding today,
Correct.
there is even slight amount of symptomatology or visual aberration, they come back to us much faster and with a larger bit of complaints.
Correct.
And
Because
deeper into what's causing it.
see, those days when you used to see advanced cataracts, total cataracts,
Yeah,
patients were happy even if they had 618, 612 unaided.
absolutely.
They used to thank you. They used to be very grateful. They never used to complain about dry eye because that visual transformation itself was so
Gratification.
significant. All the remaining symptoms used to go away. Now you're operating on cataracts which are 6.9, 6.9 plus, and they are not as symptomatic as what a total cataract would be. So for them, I think although there is the visual improvement, the rest of the symptoms, they desire that they should not be present. And definitely patients are more demanding. So even with a monofocal, your patient wants good distance, intermediate and near vision.
You know,
So you have patients come in, they get, despite whatever you explained pre-operatively and tell them this is a monofocal lens, when they come for glass appointment, they always have this, but I can't see for near. Or if you have aimed for a little bit of myopia, given them for near, I can't see for far. So somehow that they don't want to pay for the premium, but they want the premium outcome.
Absolutely. I have an anecdote on that. It's a true story. It happened with me 8 years ago. I operated an old lady and she had told her son that she wants a multifocal with a lens where she can read and see distant also. So the son came with choice. We did the relevant test. We did the surgery. And after the first day post-op, she comes to my chamber that she's very, very unhappy because she cannot read. So I looked at her autorefractometry and she was 6 by 6 parts unaided. And I said, she should be able to read. So she's telling her son that the lens is not right because, it's not doing what it's supposed to. So I asked, Maji, kya problem hai? She says, padha nahi ja raha hai mere se. So I said, padna to chahiye because aapka distance vision theek hai. So then the son laughed. He got the joke. And he told me, sir, Maji ko padna aata nahi hai. So she heard from a friend that ye lens se aap pad bhi sakte hain. So once she thought she'll get a multifocal, so she'll be able to read also. So that is the level of what the patient expectation. And this is a true story, happened to me 8 years ago. And I still tell it to all my associates that you never know what the patient expects from you.
So it's always better not to promise, 20/20 or 6/6.
Yes.
I always, no matter which patient I operate, I always tell the patient that, see, all eyes cannot be the same. There will be anatomic variations. Despite the best of intraocular lens power calculation formulas we use, the measurements that we do, we may be very accurate, but your eye anatomy may be on the outlier side, So
Absolutely.
you can sometimes have, so there can be, so if you don't explain to them pre-operatively, post-operatively, if you try to tell them the same concept, they think that you have made a mistake and now you're trying to cover up by saying
it up.
So some of these things about dry eye and, so you say that, okay, 95% you will be unaided 6/6, but there is a 5% chance you may be a little bit on the plus or minus side. If you fear that by saying that your patient is going to go away, I think rather lose the patient than to have the post-operative headache dealing with the patient. So for that, I think it makes my life post-operatively much easier if I am very frank about all these things pre-operatively and, counsel them about that.
I think that's a very good carry-on point for a lot of beginner surgeons in their practice. And I think the one punchline word I use is that 95% of my patients, 95% of the time of the day do not require glasses.
Correct.
For most of their daily routine. For something fine here and there, you may require glasses.
So I tell my patients with multifocal lenses, I told them, you will get good vision, functional vision, but you will not get the perfect vision. It's not possible.
Absolutely.
So if you're looking at a perfect vision, that all the time you should be able to see for far near, then don't get a multifocal done because it's simply not possible. The technology has not reached that point.
Yeah. Dr. Kishore Pahuja, final comments before we go on to Dr. Natasha. Sir, you're unmute.
I totally agree with Dr. Rajesh said. Patients' expectations are very, very high. You have to, sort of downsize their expectations. Once you do that, and after that, patients are happy. Even if they read 6/6, they're extremely happy because you have already told them that your vision is going to be like this. I 100% agree with Dr. Rajesh said.
Wonderful.
The only thing I would like to add on, sum up on this is when you mentioned that you're perfected the art of surgical techniques, but we are still very, very little understanding of biology.
Absolutely.
Biology is so poorly understood, and we assume that our surgical technique and the lens and whatever we are doing is going to. So, for example, that's why I posted that case that one had a microneuromy. We are a research institute. We have a luxury to do all this. But if you don't, then you'll always be wondering, same kind of a problem, why one patient gets better, the other one does not.
Yes.
And the second thing is, something which was stable for 11 years of stability of a keratoconus suddenly becomes progressive. And the culprit is not in your topography. Culprit is because you have a dry eye. So these patients, of course, every patient is important, but these patients I take it very, especially the one I 11 years, because a small judgment error is a matter of losing his job forever. Because if I do a cross-linking on him, he cannot fly. So that means that we have to be very, very cautious in understanding every bit of biology, because only then I think it gives a picture. Because biology is playing a different trick, like the coronavirus. Whatever you do,
True, true.
it has
No, that's why whatever procedure you do, no matter what the track record is in your hand. So I never promise 100% to my patients. No matter how good I can do a procedure, I can tell them that always there will be a small element of uncertainty. So I give them the opportunity. If they want to say, I don't want the procedure, I don't want to make the decision for them tomorrow when something goes wrong. The patient then comes back and says, you never told me, explained to me the risk clearly, or you were the one who made the decision for me for the. So I think it's very important. If my patient asks, can you be 100? I always tell them there's always a risk of uncertainty. There's something can go wrong, but we will try 200% to make sure that we, overcome that and we give you the best of care.
Yeah,
So unless
that's
they
right.
understand.
Yeah, hey, that's right. I mean, see, I mean, we are so advanced within our formulas and in our biometers and this and that, but still we are just fighting within a ELP. I mean, it may be any different from one
Absolutely.
patient to another. So, I mean, still we haven't found a solution for that. So that's what Dr. Rohit says. This is basically in a biology or that anatomical change that is going to happen. We never know that who patient is going to have it.
Yeah, see, the biology, as Rohit said, one of my favorite sentences is, I'm a good carpenter. I can make an excellent bed. But how you sleep on it, what kind of sleep you get on it, and how your husband gets it is entirely what is your sleep pattern. I can give you the best bed possible. So most of the patients do tend to get it.